Okay.
I'd like to introduce myself. I'm in the absence of our president, Holly Heaton. I will be opening the program today. My name is Margaret Dudas, and I'm Vice President of Meetings and Social Events. And I'd like to welcome those of you who have joined us today, ARCS members, ARCS scholars, and ARCS alumni, and also friends and supporters of ARCS. As a reminder, I would like to go over several points for watching Zoom before we begin our program. First, mute yourself when you're not speaking. Second, use the speaker mode for optimal viewing. And for those of you not familiar, it can be found in the upper right-hand corner of your screen. And third, enter questions in the chat box during the Q&A after Dr. Yan's presentation. And as Rob mentioned, we are recording the presentation and we'll post it on our website under past events for future viewing. On January 20th, 2020, the first case of COVID-19 was confirmed in the US. On March 11th, 2020, the World Health Organization declared COVID-19 a global pandemic. In record speed, vaccines have been developed that build immunity, help prevent transmission, and reduce serious illness. However, research continues on the wide range of symptoms experienced by infected people. Today's program focuses on two of these symptoms, the effects COVID can have on taste and smell. Our presenter is Dr. Carol Yan, who will be introduced by Director of Field Trips, Leslie Bruce. Leslie joined the San Diego ARCS chapter early in 2020, just after she retired from UC San Diego, where she taught a variety of classes at the School of Medicine on the politics and policy of US healthcare. Leslie?
Thank you, Margaret. I am delighted to be here and be involved in this particular program, this particular field trip. First of all, I will tell you how it came to me was that one of the best things that happens to you when you retire is that your students keep in touch with you. And Julie Carty, who is Dr. Yan's patient, who will be joining us here today, let me know that she was suffering from parosmia after COVID. And so that put the idea in my head about what a timely topic this will be. And she and Dr. Yan will go into the details of that, but that is how we come to be here today. And that's how I found out about Dr. Yan's work. Dr. Yan is an assistant professor at the University of California, San Diego, and she completed medical school and residency training at the University of Pennsylvania Department of Otolaryngology and an advanced fellowship in rhinology and endoscopic skull-based surgery at Stanford. Aside from treating patients with sinus and nasal problems, she's passionate about research in the area of post-viral smell loss. She and her colleagues were one of the first in the world to publish on the link between COVID-19 and smell loss, and has published more than 10 papers on this topic and has been featured in the New York Times, the Scientific American, and Nova on PBS. She's currently investigating the molecular mechanisms and novel therapeutics for persistent smell loss related to COVID-19 and other viruses. I think that gives people who have suffered from this hope. So without further ado, I am very pleased to introduce to you Dr. Carol Yan.
Thank you guys so much. It's such a pleasure to be here. Thank you, Leslie, for that really warm introduction, and Margaret as well. And again, this is an honor to speak to you guys. I am a new faculty at UC San Diego. This is my third year, and I'm a rhinologist as well as a surgeon scientist. And smell research is my area of passion because as a surgeon, you want to help people and you expect almost, instant gratification and cure with your surgeries, and to have people suffering from smell loss, which we'll talk more about today with Julie, is truly an area that we need more research in, and we need more therapies and people interested. So I think it's an area that I was always interested in, and now COVID-19 has kind of brought it into the limelight more than anything. So without further ado, I wanted to start the presentation today. Just want to make sure you guys can see my screen okay. So it'll be a mixture of kind of some PowerPoint slides and presentation, as well as an interview with Julie and kind of a demonstration of more relevant clinical applications. So can you see my title screen? Okay, wonderful. So again, I know relevant financial disclosures or conflict of interests. So one of the things people ask me is, why should I care about smell loss? And it's amazing because I have patients coming in and they say, I'm a little embarrassed to be here because I didn't think this was a big deal. And if there's one thing you should take away from this presentation, it is a big deal. And even prior to COVID, smell loss, and I want to group taste loss with it, it encompasses about 12% of the population, the healthy population. So we know we lose our sense of smell and taste as we age. It's very common. About 90% of people with neurodegenerative diseases, especially Alzheimer's, develop smell and taste loss as one of the first symptoms. And it truly has an impact on quality of life. So not only does it have an increased risk of mortality, actually increased risk of death is what statistics have shown compared to sight loss, hearing loss. It actually causes you to be more socially withdrawn. You stop getting pleasure in social activities, in your meals. And so it actually has quality of life issues as well as health safety issues. So certainly think about all the times that you may have been close to burning something and while cooking, and you won't be able to smell or taste that. So loss of taste is very closely associated with your smell. And that is because by far the majority of your taste is truly flavor. And that's from the molecules that come from the nose that kind of go in and adjust your sense of taste. So one taste, you can taste that something's sweet, but you wouldn't be able to tell me, is this watermelon flavor or cherry flavored without your sense of smell. And then importantly, people actually have really bad self-recognition of smell loss. So it's amazing when people say, I think my smell is okay. And then you test them, and we'll go over smell testing today. And you realize they actually have moderate smell loss, or maybe even more than that. And so it's because of all these areas, it's actually been a priority area for our government and the NIH, and the one of the branches of the NIH for research. It has been known to be a area of strategic area of research that they want to focus more on. So from the academic side, there's also this impetus to try to understand it better. So let's talk about COVID-19. So to date, there are around the world approximately 255 million COVID cases. About 50% roughly have smell loss associated with them. And of those, they found that now 10 to 20% have what we consider persistent olfactory loss. And that's people who've lost their sense of smell for at least over 3 months or so. Who knows if longer? But that really means it's a staggering new number of people out there, with over 15 million people now with persistent, what we call olfactory dysfunction or smell loss or smell alteration. So I want to show you this picture, and this study was published well over a year ago, and this is even very early on in the pandemic. You can see each dot was a publication of research that was taking place with COVID-19. And a couple of things to look at is, one, smell research was a very hot topic back then. And sorry about that. And you can see our little dot here reflects San Diego and some of our studies early on. But it was very much, COVID was so prevalent in Europe and Persia and Iran, and Persian upsits and smell testing was very common. And so you see that. And actually, it's interesting when you see prevalence, the kind of the color of the dots, you see that the Western countries seem to have a higher prevalence of smell loss, like 50% or more, versus the Eastern countries in Asia, the prevalence seemed to be lower in these reported tests. And so they think maybe there is sometimes a either ethnic or genetic component to who is getting smell loss and who is not related to this virus. So since then, just to reiterate how much smell loss has come into the attention of the public eye and the media, there has been so many publications and articles of people who've lost their sense of smell, and often really well-known chefs and sommeliers who really impact their career and their whole livelihood have lost their sense of smell. And I was in Denver for a research meeting and met one of these chefs recently, and he was featured in the local Denver paper, and he's one of the restaurateurs in the area and that has lost his sense of smell, and it's quite devastating, as Julie will talk about a little bit more. And because of that, there has been the rise of different social media groups. So these are two groups on Facebook, and actually that's how I met Julie. Is she reached out to me after hearing my name on this Facebook group, but you can see there are almost 40,000 members in each group, and that just kind of goes to show these are the people who have come together and kind of solicited help from one another about their smell loss and smell distortion related to COVID. So at this time, I just wanted to take a moment to introduce Julie, kind of get her point of view. And I think that's so important to talk about what she's gone through and, you know, get the first person perspective on what smell loss really does to your life and kind of how it changes your perspective. So thank you, Julie, for coming in on here today and speaking a little bit more on a personal level about your sense of smell. Can you tell us a little bit more about your experience, the moment you lost your sense of smell, and then also the moment you realized you developed this distortion of smell, which is the parosmia that we've been talking about?
Sure. Well, first off, thanks ARCS for featuring Dr. Yan's work, and thank you, Dr. Yan, for your work. So I realized I lost my sense of smell about 1 week after I tested positive for COVID, which was December 24th, 2020. So lucky me. I also was 9 months pregnant at the time. And about a week in, I noticed that some of my skincare products stopped smelling. I noticed that the foods that I were cooking and just the scents around me that I'm used to were gone. And that was about a week after testing positive for COVID. Then my smell loss lasted for close to 4 months. And I never was able to get that newborn baby smell. I never smelled my son, which was extremely depressing, as you can imagine. And I thought that was probably the worst of it until, like a light switch, on April 17th, 4 months post complete smell loss, I had parosmia set in, which I learned is distortion. And so I was cooking dinner. I remember the exact moment it happened. I was cooking dinner for my family, and I tried tasting something that I was cooking, and it tasted rotten. It tasted like it had gone bad, and had my husband try it, and he looked at me like I was crazy because it was perfectly fine. And then everything around me in my house started smelling like of a smell that I had never smelled before. The only way I could maybe put it into words is close to sewage or hot garbage. It was just awful and putrid. And parosmia lasted for close to 4 months in terms of the severity of parosmia. Everything around me and everything I was eating was that just putrid taste and smell, which us parosmics call the COVID smell because it's the only way we can describe it. And after 4 months, it's when it started to dissipate again. And now I'm back to minimal smell to no smell. And sometimes I'll still get flashes of that parosmia smell. And about like maybe 3 times a week will I eat something completely at random where it tastes awful and it gives that awful taste. And and I never know what it is. There's no rhyme or reason to it. It just, something sets it off, and it's pretty hard to stomach. So if you're talking from my entire timeline of dealing with smell and taste issues, it'll be 1 year on December 24th.
Yeah, sorry to hear that. And the timeline that Julie's talking about is very classic for the onset of parosmia. Like she said, it's about 2 to 3 months after you initially get your smell loss from COVID. And parosmia is nothing new. We've talked about distortion of smell in the field before, but it's just terrifying how many people develop parosmia with COVID-19 long haulers. I would say our research has shown about 50 to 70% get it. So Julie, what is worse for you? Is it the ability to have is it the lack of smell and having no smell, or is it the distortion of smell?
Without question, the distortion was worse for me. When I had my newborn, I didn't have time to really deal with my smell loss. Sure, it was super depressing that I couldn't smell anything, but once that distortion set in, it made the day-to-day pretty much like almost, I couldn't handle it. Everything, you don't realize how much smell and taste affects your life. From the moment I wake up, I couldn't brush my teeth with my toothpaste instantly because mint tastes like garbage. Couldn't make breakfast for my daughter. Everything around me smelled just horrible. And my own newborn started to smell like that garbage smell, and which is just awful and depressing. And so I learned early on that I had to switch out every product in my house to be fragrance free. But definitely the distortion was beyond much harder to navigate than smell loss. In fact, there were points of time where I just wish I could never smell again, ever, just to make the distortion go away.
Yes, and I've definitely heard that from patients. I mean, I have people coming in tell me, can you just take out my olfactory bulb, like your smell organ, so I can just never smell again. And, unfortunately, there is no cure for parosmia. There's not even great, at this point, really effective treatments for it, to be honest. So, Julie, what do you think has helped you cope with it the best? And like, what has helped you? Is it just time? Is it just mentally having a good attitude? What do you think?
Well, I think early on, I did what most people do. I went to Google, and that's when I came across that Facebook support group. And I'm a strong believer in those groups. I've used them for other things, and it brings you a sense of community and it validates your feelings. So I think finding that Facebook support group was key, and a turning point for me to have some hope and some faith and a network around me. Because I also, that day when I logged into the Facebook support group, ironically saw that you had posted a study. And then I also reached out to some contacts within UCSD and said, is there an ENT you suggest? And so that's when your name came up again. So it was just lucky timing on that. But the Facebook support group early on helped me navigate, safe foods. So while it's not the same for everybody, but the majority of the people in this group have the same aversions in terms of what they cannot tolerate, like meats, eggs, onions, anything like floury, that all kind of triggers it. And then there's a common safe flavor of vanilla and the scent of vanilla, and also cinnamon. So I went and got cinnamon toothpaste. I changed all of my shampoo and conditioners to vanilla. And I changed out all of my detergent to fragrance free. So that Facebook support group was key in helping me navigate, because if I didn't find that early on, I wouldn't have known to drink vanilla protein shakes, which is quite frankly all I drank for 4 months, which was pretty tough to deal with. So I would say that was helpful. I also learned about smell training, which I know you're going to get into, but smell training I think has been very helpful. It's essentially like physical therapy for your brain and your nose to reconnect. So what you're going to do is you smell the same, scents every day, and you think about it and you look for what it's supposed to smell like. So I think that was really helpful. When I obviously saw you, you told me to, incorporate nasal rinsing. So I think that helped. And I also added in omega-3 to help with the inflammation. And then just small things like I bought a nose clip, like a swimmer's nose clip. And I put that on when I was cooking dinner because life had to go on. I have a toddler and a newborn and a husband. So I use the nose clip to try to stomach through cooking. I use the nose clip when I, needed to get food down myself. I went and saw an acupuncturist because, acupuncture is shown to help with nerve regeneration. And while it helped, I don't know, but what I can tell you is that it did help with my mental state. I was suffering obviously from a ton of anxiety. I was really stressed out. And so the acupuncture helped with that. And so that is maybe arguably, just as important, if not more important than dealing with trying to regenerate your, your nerves. And my husband had a great idea because I obviously had to go, out of my house at times. And so he said, why don't you put vanilla extract inside your mask? And so I would put vanilla extract inside the lining of my mask so that it would mask the odors when I would go to the grocery store, or if I had to go and pick up my daughter from school and I would come across that smell. So, I sought out a mental health therapist. I never went to one before. And I just knew that, this was going to be really challenging to navigate. And I thought I couldn't do it alone. So those are the things that I did that I think helped. And then, time, right? I think time obviously is going to help as well.
Yeah, that was awesome, Julie. I feel like you could give this presentation now. And we didn't rehearse this at all or anything, but seriously, this is like, it's just really great to hear kind of your perspective. And this really resonates with really what I've heard over and over again from all my patients. And so thank you so much for sharing that. What is the one piece of advice would you give to someone who, we just went through another COVID surge. There are a lot of new people now with just recently developing parosmia or COVID anosmia. What would you tell them at this point?
I mean, obviously all the things I just mentioned, I would do. Another thing that I suggest, so I joined the Facebook support group, but I think it's really helpful to have your family and your friends join that Facebook support group. I'm super fortunate that my family was extremely supportive, and they understood as best they could, with what I was going through. But when they joined the support group, they were reading and seeing these stories from individuals that were on feeding tubes and that couldn't stomach water. There were people that were in severe depression. There's mothers in this group that were dealing with toddlers that are, going through this. And so I found that, like, while I have a very supportive family, but I think it's helpful to have someone else be the mouthpiece and for someone else to hear other people's stories so they can truly understand, because in this group, I've come across people with their families, they don't understand. And I mean, how could you understand what this is like? And so I think that will help. So I do suggest, if you find yourself with anosmia or parosmia and you're struggling with getting people to understand it, have them join the support group so they can see that you're not alone. Other people are going through it. You kind of talked about it contributing to, health and safety issues. I'd say get a smoke detector and make sure it's working, because there were times when I had no smell, but I would burn something and I had no idea. I could not smell it. So that's something that's, I think, important. And just take care of your mental health. You have to take care of your mental health. So, you need to focus on that along with the smell training.
Yeah, great advice. Absolutely. And everyone has it to different degree. And I will say having the support system is really important because it does vary. And I will say also, even coming from a provider standpoint, from a physician, we didn't know about parosmia. We didn't realize how hard it would hit with COVID-19 related smell loss and what prevalence it would be. So I will say, like, I'm a ENT rhinologist. I think about the nose day in, day out, night. I have a special interest in smell, but so many primary care doctors, the other ENTs have come to me like, have you heard of this thing like smell distortion? I'm not sure what it is. And so the initial thought was it's psychiatric, or it's, COVID related to effects on the brain. And, and so definitely having a support group is really important.
Yeah, actually, I'd like to add that point. I find that a lot of people think there's no cure So why do I go to a doctor? I don't think just because there's no cure, or maybe your primary care like mine doesn't know what parosmia is, you should still go and see your doctor, because the more the medical community has exposure to us, the better it is going to be for all of us. And my primary care may not have known about it when I saw her, but I actually helped educate her. And then now she knows what to do with it for the next patient. So I don't think you should just not go to your doctor because there's maybe no cure. You should always just still see your physician, and obviously try to see an ENT like yourself, Dr. Ian, if you're fortunate to have someone that, is an expert in that in your area.
Thank you. So I want to come back to you and talk about a little bit more treatments in a little bit. I'm going to go back and share my screen for a few more slides to go over a little bit more about the science and kind of what we've found about the distortion and the smell loss. So let me share my screen one more time. And then I definitely want to come back though and talk more about the treatments and get Julie's perspective, because that's so important. Okay, so because it is really important from not only a personal view, but also from a health literature view to really understand the impact of quality of life on smell loss and COVID-19 related smell loss and distortion. Our group is interested in studying from the clinical side the health value of it. And so this is a commonly used term called health state utility values, or HUVs. And it basically has someone rate their health from 0, as in they're death, to 1, perfect health. And it's used in healthcare economics across all fields. And it basically says, what is the quality adjusted life here? So if there is a therapy, let's say in the future, which we hope there will be for smell loss, how much does additional year of life that this therapy can give you, how much does it really benefit me? And it's important for diseases that are, let's say, not cancer or life or death diseases, but more quality of life affecting diseases. And so that would be smell loss, migraines, for us, sinus disease. How much does that give you in terms of your health? And it also allows for cost-effective research and pharmaceutical kind of development. So we asked our patients, both on the social media platforms as well as our own hospital patients who have been COVID tested, who've had COVID-related smell loss or distortion, certain validated questions. And this is just a sample of some of them. So one is we use the EQ5D, which is this European scale, and it basically looks at health state values. And these are basic health, this is mobility, self-care, can you perform your usual activities? This is not specific to smell, it's just kind of everyday pain, depression. And then it tells people, can you rate your sense of health on a scale of 0 to 100? Where are you today with it? And the interesting question that's a little bit more specific to smell is what we call the time to trade off. And it basically is saying, how many years of normal smell, let's say you have 20 years of normal smell to live, or sorry, 20 years of complete smell loss to live. How many years would you give up to have normal smell? So what is that equivalence to you? Normal smell, number of years, and 20 years. So I asked my husband this, who's never had smell loss, and he's like, that's a ridiculous question. He's like, why would anyone give up any years for smell loss? And you'll see when we survey our population, how different that response is if you truly had smell loss. So that same question, time to trade off, when you look at the health utility values, sorry about that, it was very glitchy. You're actually seeing that it's at 0.5. That means on average, the people who've had persistent smell loss and recovered smell loss are willing to trade up to 10 years of their life for perfect smell compared to having 20 years of complete smell loss or complete smell distortion. So that's actually very significant. And what we also see is that in the other types of healthcare status measurements, the red line is the overall population norm. This is when you survey people that same age. This is across the US. What is their overall health and that's around 0.86 for this survey. So those who've had never had smell loss in COVID, they're kind of at that same range. And those who've recovered their sense of smell, when you ask them, they're again at that same range. But when you see those who've had persistent smell loss, and that's really the only difference between all these cohorts, they are at a lower health utility value. And this kind of gap might not seem like a big deal. And you're seeing this again with different types of measurements of health utility. Those with a persistent smell loss have generally feeling like they're at a lower health today compared to those who've never had smell loss and recovered smell loss. And this is all other things being equal. And this is much lower than the overall general population. So again, this gap may not seem like a huge deal, but I wanted to show you compared to other disease states across the board. So this is looking at people with COPD, breast cancer, HIV, and let's say migraines. How do they feel about their health? So the higher the dots, the better they feel about their health. The lower the dots, the worse. So when you ask people on average, those who have persistent smell loss, they're at this line right here. So it's kind of puts smell loss in perspective with those who have a lot of other chronic diseases, certainly much worse than those who report migraines on a regular basis, worse than those who report seasonal allergies and high blood pressure, maybe not as bad as those who have HIV and renal failure, but we're talking about pretty severe diseases. And they did a word cloud actually in a study looking at the most common triggers of parosmia. And you can see the bigger the word, the more commonly it was triggered. And so, as Julie also mentioned, it was mint, onion, meats, coffee. Coffee, I mean, how often do you see that at work, at home? And so it's not just about you not drinking coffee at home, you go to work and it's in the offices so often. So this is the kind of things that you often aren't able to get away from. And when we looked at health utility for those specifically with parosmia, not only do they have overall lower health scores and their self-perceived health is much lower than those without parosmia, when you look at kind of the areas that they're really struggling with, it is in the area of pain and anxiety. So who are the people who get persistent smell loss? Like, what do we know about them? So clinically, what we found is that those with parosmia tend to have persistent smell loss, which makes sense. And that I don't want to make too much of that correlation because simply you get parosmia at that 2 to 3 month mark. So if you're getting parosmia, you probably are one that has a persistent smell loss. The female gender seems to be a variable that has increased risk for persistent smell loss. Age and greater severity of loss up front is also related. And then let's talk about pathophysiology. So, you know, we have improved our understanding of why did we get smell loss in the first place with this COVID virus. The SARS-CoV-2 virus, as many people have now heard, it likes to attack certain proteins that are found in our cells. And specifically the receptor that this virus wants to bind to is the ACE2 receptor and then the TMPRSS2 receptors. And these are common receptors that are found in the nose. So this is an mRNA data looking at the different types of cells in your nose. And specifically, you know, of note, in our nose, 99.9% of cells are what we call respiratory epithelium. But actually deep in your nose, that tiny little 1% of cells are responsible for the human smell in your nose. And those have totally different types of cell types in there. And that virus loves this type of cell, they think is the succinacular cells. And those have just high levels of these two proteins, receptors that are there. So this virus, they think, doesn't bind to the actual smell nerves, they would bind to these succinacular cells, and they're the supporting cells for these nerves. So what happens is the support cells die off. It basically doesn't give the support that it needs to the neurons, and potentially the cilia and the parts of the neurons function die, and then you lose your sense of smell. Well, in best case scenario, these supporting cells regrow and there are stem cells in the area and they regenerate. And so we have people 2 to 4 weeks later saying their complete self smell is completely regenerated. And that's what's happening for about 80% of the people, which is great. And so the neurons, the actual smell fibers never actually die. It's all the supporting cells and they get replenished. What about those who don't regain their sense of smell? Like I said, this could be over 15 million people. Why are they getting persistent smell loss? And so it could be lots of different things. And that's what we're kind of trying to figure out. And that's what my research is trying to garner a little bit more of a clue, because we really have no clue. Is it infectious? Is it because the immune system is still present and it's fighting off, more inflammation? Of note, females are known to have a stronger innate immune system, so compared to our male counterparts. So is that why maybe females are getting more persistent smell loss? Is that their immune system was stronger and reactive more to the virus? We also published a study very early on that's been held by many of our colleagues to be true, that those who had really mild forms of COVID got the smell loss, So it wasn't as commonly those who were on ventilators and they actually didn't have much other symptoms besides their smell loss. So maybe their immune system is actually stronger, and by that, they're still triggering some type of localized immune or inflammatory response. And that's kind of one of my theories. Your sense of smell and the smell bulb is actually in the brain. And so we talk a lot about the nose, we try different therapies in the nose, but it's possible that a lot of this is still, injury to the brain. And so is it possible with the parosmia and the distortion that there could be more long-lasting effects in the brain that we don't know about? And then is there any genetic factors? So one group in France, one cohort published a study recently that was really interesting, and they found in a couple of the long hauler COVID cases that there was actually persistent virus there. And it's fascinating because these people, are 6 months out, they've totally recovered. You do PCR swabs on them and COVID testing on them for their nose, and everything's negative. They're doing great, but they still have smell loss. And then when they look at that olfactory cells kind of deep in their nose, they're actually seeing that there is actually presence of virus and seems to have higher viral loads than those that had just acute smell loss. This is kind of a staining of viral proteins, this NP, a nuclear protein of the virus, and it's showing that there seems to be cells related to where TUJ1 is an olfactory marker is. And so, this is a very profound hypothesis. Could there be persistent viral load in that area causing smell loss? And I would say this one study isn't enough to really, for us to know one way or another, but it's a really interesting theory. In our lab, we're kind of looking into the cytokines in that area. So I actually have been swabbing some of the mucus from my patients from that olfactory cleft and looking at, are there inflammatory cytokines and antiviral cytokines? These are kind of markers of inflammation that's being secreted by those cells. And is there an upregulation in those with COVID compared to controls? And we are seeing, some differences. One is examples of beta, and this is still pretty preliminary data, but kind of perplexing and also showing could there be more of an immune response going on at the time? So that's kind of some of the biological theories and pathophysiology. I wanted to take you to a more practical level of what happens when you see me in clinic and going to see a doctor for your smell loss. So I want to take you to a visit in our ENT clinic. And I pre-recorded a video of some of the smell testing that we do. So this is Julie taking the smell test called the University of Pennsylvania Smell Identification Test. And it's this 40-question scratch and sniff test. You can see her bubbling in the right answer or whatever she thinks is the right answer after scratching off the scent. And it is a forced guess. So even if you don't know it, pick an answer. It's one of the most validated smell tests out there that basically has 40 odorants that are supposed to be culturally significant to your country. So there's actually different versions depending on where you live. And you can see an example of this odorant most commonly smells like.
You know it's bad when you can't differentiate between skunk and pulla. told me it's not either Coca-Cola and it's either mint or fruit punch. So that's how life is going these days, but at least I'm in a mental place where I can laugh about it at this point, but it's taken me a long time to get there.
So we're back again, and here we're going to demonstrate one of the other small tests. This is called the sniff and sticks. It's developed by Professor Hummel in Germany. It's actually a 3-part smell test. So unlike the upsit that only focuses on smell identification, this one actually is administered to you while blindfolded. So Julie now has a blindfold on, and it's looking at your ability to detect threshold. So how strong does the scent have to be to smell it? It also looks at smell discrimination. Can you tell the difference between 2 different scents? And then there's a third part called similar to the upsit with the smell identification. So first, I'm going to give Julie the one scent that she can smell and see if this is the target scent that you're trying to smell. It's very subtle. So to be honest, a lot of my patients can smell the scent.
I don't really smell it. I smell something that I'm going to want.
For the purpose of that is actually the correct one. So normally was that okay? Could you see that video? I heard it maybe was a little bit choppy in the signal. The second test that we had recorded was basically what we call the sniff and sticks test. And it's a 3-part test. And it requires you to be able to smell a certain really faint scent. And it's like, well, what threshold can you smell it at different strengths? And then the second part is, can you discriminate one scent compared to 2 that are totally different and say which one is not like the rest? And so the sniff and sticks is a little bit more granular of a test, and it really counts on your ability to, how strong does a scent have to be for you to smell it? Can you tell differences? And then can you identify? So the upsit and the sniff and sticks are probably the 2 most validated and most commonly used smell tests to really test your sense of smell. And I'm going to actually just verbally kind of go over what we do here, but I wanted to show you an example of what we do in our clinic all the time to evaluate the nose and where the smell fibers are. So this is an example of what we call a rigid nasal endoscopy. And this is me putting a camera in Julie's nose. Often we do numb it up a little bit because it's not comfortable and it looks very intimidating, but only a little bit of goes inside the nostril. So you can see here, Julie has a very nice straight septum, which divides the right side and the left side, and it's nice and pink and healthy. And all this is just regular tissue. None of this is smell. This is just your nasal lining. People, when they get congested, report swelling of these structures called the turbinates. And you're seeing here the middle turbinate right here and what we call the septum right here. Again, very healthy lining the nose. That's what we see with COVID-19 is that it looks good, and it typically does. Your smell fibers, you can imagine, this is quite deep inside the nose, are right here in this crevice. And it really is in this little cave between what we call the middle turbinate and your septum, up high between your eyes. That's where viruses are having to attack your nose if you're truly trying to get, if you truly get smell loss. And so again, Julie's scope exam is perfectly normal, looks great. And most of my patients' scope exams are really normal too. And so it's worth taking a look because you don't want to miss out on someone who might have sinus disease. Certainly we see people who have tumors there, who have polyps there, and that could be a cause of smell loss unrelated to COVID-19. All right, so at this time, I want to bring back Julie to talk a little bit about some of the therapies we have about smell loss. And so by far, like Julie mentioned, smell training is the #1 thing to try. And regardless if you have parosmia, if you have anosmia, hyposmia, this is safe. This is done by yourself at home, and it is, like Julie mentioned, almost like a cognitive behavioral therapy. And it seems really simplistic, but it truly does work. And you take 4 odorants typically of a different smell palette, kind of across what we call the smell prism, and you practice smelling them. And it truly is a intentional kind of smelling repeatedly, twice a day at least, for about 20 seconds each for about 3 to 6 months. And I will just mention that there is what we consider in our medical literature grade 1A evidence. That's supported by randomized controlled trials, meta-analyses, systematic reviews for improvement. And specifically with post-viral smell loss, mostly with other viruses, because we don't have that much literature on COVID-19 yet, we see an improvement in at least 30 to 50% of our patients. That's clinically meaningful, which means the MCID is achieved. All right, so I'm going to stop the share for 1 second and just kind of have Julie show, how she does the smell training, because there is a way to do it correctly. And
yeah, so I have my little essential oil. This one happens to be lavender. And then what you need to do is you can't just sniff right out of the bottle. You need to put the oil into a container that has a wide mouth so that your nose can fully get over the aroma. So I just do a couple of drops in this little container here, kind of like split around. And then I actually also use an image of the scent to try to really help reconnect my brain and really think about what it is it's supposed to smell like. So I have a picture of lavender here. And so what I'll do is I'll just hover over and just take some little short, deep sniffs in. And I'll do it about 15 to 20 seconds. And I try to think about lavender, what lavender is supposed to smell like. There's honestly days where I smell nothing. Like today, I genuinely smell nothing from here. And it's kind of interesting because I will have my husband smell it and I'm like, does this smell? And he'll be like, that is extremely strong. So there's days where I smell nothing. There are days where I smell, I can kind of get it through. And then when obviously I had parosmia, when I started this, it smelled extremely distorted. It smelled like that putrid garbage smell. But I do feel I've seen improvement. The fact that I can smell like that, I don't smell that garbage smell anymore, to me is a win. And there are days where I will have that lavender or the clove or the lemon, whatever the scent is, come through. And then I personally keep it now in a little baggie that I can take with me. So I don't, I think it's important to be consistent with it and, to not lose hope. And so I actually put a little quote on my bag to help me keep doing smell training. And it says, your struggle is real, but never lose hope. You never know what tomorrow may bring. A little training each day can add up to big results. This is tough, but so are you. So it kind of keeps me going. It keeps me, today I couldn't smell anything, but maybe tomorrow I'll get hints of that lavender. Or maybe tonight. So that's kind of how I do my smell training. And I do that twice a day along with nasal rinsing, which I think you're going to show on your screen next. But that's kind of smell training in a nutshell. It doesn't take too long of time to do.
Perfect. Yeah. And Julie hit right on the nail where, the scents that you're using, there are 4 popular ones because that's what the literature had originally written about. And this was developed by, again, Professor Hummel in Germany, who I consider the guru of smell research. He used, which is rose, eucalyptus, lemon, and clove. There's nothing special about those 4. The most important thing is that they're different from each other. So you don't want to use 4 floral. You don't want to use 4 fruity. They need to be, again, different scents across a prism of scents. The most also important thing is that you're familiar with them. So if you're not familiar with what eucalyptus, let's say, smells like, you shouldn't be practicing smelling eucalyptus. The idea is that you're reminding yourself. A lot of people do like to look at a picture of this and kind of remind yourself, what does eucalyptus smell like? Today it might smell distorted, it might not be as strong, but I'm going to keep kind of training. So it truly is a cognitive behavioral therapy for the olfactory nerves, they believe, and it really is strengthening the connection. So I know I didn't mention this earlier, but your smell bulb is in the brain. It descends and it has sensory neurons that go multiple layers of neurons into the nose. And so when the virus attacks the nose deep inside, there is a replenishing population of stem cells that will regenerate these viral sensory neurons, attacked sensory neurons in the nose. They have to regrow and reconnect back to the brain. And that's where all the processing occurs. So there definitely needs to be a kind of a training process in a lot of patients. This isn't something that happens over time. So typically 3 to 6 months is what we tell people to use. So thanks, Julie. All right, and then just to go back to the presentation. So Julie has touched upon this again. And the other thing I do recommend is saline rinses with the medication. That's an off-label use of a steroid. So budesonide is the type of steroid that I highly recommend, but it basically, the easiest way to think about it is like putting Flonase, which often people use for nasal congestion, and putting Flonase in a rinse bottle, a bottle form that's higher volume, because really a spray doesn't get to the area of the smell fibers. You saw how far it was in the endoscopy. So you need something that's a little higher volume of rinse. And so we like the squeeze bottle form. And I actually have a video, but for the sake of time, I won't show it to you, but you lean your head forward over a sink and you kind of flush it into your nose. And it's helpful to do it over the shower or the sink. And you're putting basically sterile water, either like distilled water or filtered water or spoiled water, a salt packet, because that balances the pH, and then this medication. So this medication is an asthma medication. And it is off-label use. We've been using it safely for 30 plus years in rhinology for our sinus patients. And we did a clinical trial previously looking at other post-viral causes of smell loss. And we found that the use of budesonide versus just rinses alone had a significant difference in the smell function testing after a 6-month use period. And in fact, so on the odds ratio, it was actually adjusted almost 4 times as effective compared to just rinsing with saline alone. I just want to point out that there are many ongoing clinical trials. Truly, as you guys have now kind of gotten the impression, this is something that impacts so many people. There really is not great therapies. Like there's no magic cure that we have for smell loss, and particularly parosmia. So these are kind of some of the compounds that are being researched out there, and some of the clinical trials. You can kind of find more information about them on clinicaltrials.gov. And I do encourage people to look at them if they're willing to participate. So one clinical trial we are doing here at UCSD in conjunction with Stanford University, where I did my fellowship, is the use of PRP, or platelet-rich plasma. And that's actually your own blood product. So it's actually a peripheral blood draw. You're drawing your blood and you're spinning it down for the really higher concentrations of platelets. We're talking about like 5 to 10-fold concentrations of platelets with very low blood cells, red blood cells and white blood cells. So the idea of PRP is that it has higher concentrations of growth factors and anti-inflammatory cytokines, and that those include things like VEGF and platelet-derived growth factor and TGF-beta. And this is something that's been used a lot in the medical field. So certainly orthopedics is very popular, in facial plastics is popular. I believe the Kardashians popularized it once when they did the vampire facials. People do it in conjunction with microneedling. But we were interested in it because specifically it's been used in other peripheral neuropathies. So carpal tunnel, leprosy, things that cause nerve damage. And so the idea is we're using PRP in treating in the human nose and seeing if there's an ability for regeneration of these peripheral neurons. So they did a small study a few years ago in a mouse, and they basically flushed the mouse nose with PRP treatment. And in a mouse, how do you tell when they lost their sense of smell? You actually do what we call a buried food finding assay. So you hide the mouse's pellet in a lot of in a lot of shavings in their little bedding and see how long does it take for them to find it. So these mice were chemically induced to have smell loss. They kind of got a lesion that made them have smell loss. And so you can see in the two groups, they had smell loss from day one, everyone had smell loss. And then at 21 days, those who got just placebo still couldn't find, in this one, still 3 of the 8 mice couldn't find the food versus, and the ones that got PRP were 100% successful in finding the food. And that's just kind of a simple, although very small, powered behavioral study showing that the mouse, it seems to have better sense of smell with the PRP treatment. And they actually looked at histologically in the mouse that there was less damage to the cilia, that kind of lining of the epithelial cells in the nose in PRP versus it's completely gone in the saline, and there's less damage scores. So a small study, kind of preliminary in a mouse. We actually did a pilot study a few years ago as well, prior to COVID, looking at the use of PRP in treatment of olfactory dysfunction. And we kind of recruited patients with mostly post-viral smell loss. We think it's related to other things, most commonly like rhinovirus or influenza or parainfluenza. But prior to COVID, you never knew which virus caused it. You just knew that they lost it from a virus. And we actually found some improvement. We did sniff and sticks kind of at 0, 1, and 3 months. And so that kind of study and the importance is that no one did worse. Like, we did not cause any smell loss. And that's really what we want to make sure is that we're doing no harm. That study has allowed us to kind of pursue this randomized control trial using PRP. And so we're actually recruiting patients. We're kind of nearing actually the end of our study in the next few months, but we're recruiting patients that have had smell loss with COVID for over 6 months and less than 12 months. They're getting 3 consecutive treatments of either PRP or sterile saline. We, again, like you harvest PRP by doing a peripheral blood draw, just like you would checking your blood anywhere or donating blood. And then we spin it down in a special centrifuge in different kits that allow us to harvest the PRP portion. And then we're actually injecting it into the nose. We're actually testing their sense of smell using those sniff and sticks at baseline and then 1 month and 3 months after treatment. And so this is kind of a video of just what it looks like inside the nose when we're doing the injection. So we've numbed it up. This is someone that got the PRP. It kind of looks like really faint blood. So again, this is the middle turbinate. This is deep inside the nose. And then this is your septum, that middle wall that divides the right and left side. But high up in this area is your sense of smell. And just on the other side is the brain and where your smell bulb is. So we're taking a fine needle with the injection of PRP. We're going underneath the lining of the mucosa, that lining of the nose, and we're injecting about 1 milliliter of the substance on either side. And again, importantly, we haven't had any really significant side effects from this treatment. We have not had anyone who lost their sense of smell or really worsened their sense of smell with this therapy. So it is a little bit of an investigative treatment, but again, with at least at this point, no adverse outcomes. So it does help when they have a relatively straight septum. From a surgeon standpoint, it helps with that. And then you can see, and this whole procedure, this injection portion takes about, I'd say 30 seconds or so. The longest part is just making sure they're comfortable, they're completely numb. So I'm just to wrap this up, I wanted to just go over some of the things we've highlighted is just that support is one of the most important things you can have with smell loss, and an understanding of that. One, it's not just affecting yourself, but also that 2, it does affect quality of life, and you shouldn't be hesitant to talk about it and tell your providers, your healthcare providers about it. And so there are a couple of nonprofit organizations that have traditionally been really great, and even prior to COVID, big advocates for smell loss. And so that's would be Absent and Scent. Social media, we highlighted some of the Facebook groups, and certainly other social media platforms have similar support groups. And then most importantly, to tell people about the safety measures to take, spoiled foods, the potential for smoke, and having working carbon monoxide alarms at home is really important. So I just wanted to thank you guys so much for letting me speak today. Thank you, Julie, and the whole entire ARCS team. And these are just some of the people I work with, both in the lab and clinically as well. So thank you.
Thank you so much. We do have a number of questions. If anybody else has questions, by all means, put them in the chat box. We have a few that I'm happy to present to Dr. Yan. I think the first one came from Minerva, and I am just having a peek at that one. Here it is. Is there a molecular basis for the predominant perception of, quote, sewage smell over other smells, such as a greater amount of olfactory receptors for acidic or bitter smells?
Yeah, that's a good question. And we don't know. We don't think it's a specific number of receptors. Certainly, Jane Parker, who's one of the well-known chemists who studies parosmia, found that there are certain common compounds. So she actually took different compounds from coffee and isolated them and actually presented them to people with parosmia and not. And they actually found that molecularly there are certain compounds that trigger parosmia. Sulfides are a big common family that is a trigger point, but it's not common for everyone. And it's not all certain types of receptors, or we think it's specific to certain receptors, but we're not really sure if there's a certain category. But again, we don't know exactly in terms of from the patient's standpoint, is there something in their olfactory system that's different?
Very good, thank you. And sort of on that same general tack, we got another question, was wondering something similar. I am wondering if some of those trigger odors in the word cloud are also seen as triggers in other conditions related to smell.
Other conditions as in other types of parosmia, or
are there other kinds of smell issues that are not viral related, in other words?
Oh, I see. Yeah, so definitely parosmia. If you ask, actually, there are surveys I've done on parosmia even much earlier than COVID, and yeah, certainly we can see parosmia in those post-traumatic after, like, let's say car accidents and things like that. They hadn't been as heavily uniform, I would say, to those certain scents. So I think there is something common about this COVID-19 virus, the SARS-CoV-2 virus, that is triggering these specific odorants. But parosmia as a whole, and phantosmia, which is the feeling that you smell something that's no one else smells, that it's not there, has been very common in both neurodegenerative diseases as well as post-traumatic smell losses.
Very interesting. Will the PRP treatment be a cure, or will it need to be repeated at intervals?
Yeah, it's tough to say. I mean, I will say, because we've already done a fair amount of it, it's not going to be a flat out cure for sure. And and it makes sense, because we're just ultimately hoping to stimulate anti-inflammatory or pro-neuronal growth in the peripheral olfactory nervous system, kind of along those olfactory sensory nerves. And so certainly I have not seen it be very helpful for parosmia, unfortunately, because the idea of parosmia is that maybe these neurons are functional and fine, but there is a misfiring of the wiring between these neurons into the brain. And so maybe it's more of a linkage, or maybe of a peripheral neuropathy itself. And the PRP doesn't seem to help people who have profound smell loss. So if you can't smell anything, your smell score is so low on the UPSID or the sniff and sticks, I've not seen as much of improvement as those who have kind of moderate smell loss.
I see. Here is, I think, Michael Rader, nasal rinse with budesonide has helped my smell loss. And
Yeah,
is that the one you were mentioning?
Yeah, definitely. That's great to hear. And I think the fact that it has been helping people with their smell loss does show that this is not all just a central process, that people with long-term smell loss, there's still something which kind of goes along to that maybe there is something that's still inflammatory in the peripheral nervous system.
Okay. I wondered if Julie might be able to relate the story of the woman who was hospitalized in Spain and couldn't get out because they didn't believe her. And I think that really speaks to the complete lack of understanding that in the broader culture about parosmia. And if she could relate that and the importance, as you have told us, about the support groups.
Sure. So one late night when I was nursing my newborn, I was on the Facebook support group and I saw that this girl actually was in Italy. She messaged in the support group asking if anyone had had an MRI and did the MRI show the damage. And I had just had an appointment with Dr. Yan, and I had asked her about an MRI, and she had informed me that unfortunately, these don't typically show up on an MRI because there's, as you saw in my exam, there's no damage, there's no physical damage. It doesn't get picked up on an MRI. So I relayed my information to her, and then she responded back and said, well, I am in a mental health, I'm locked in a mental ward at a hospital. I went to the emergency room because I haven't eaten anything for 2 weeks. And so my mom took me, and they never heard of parosmia. They actually thought I had an eating disorder. And so they have now put me in like the eating disorder area, and they don't believe me. And they're going to order an MRI to show that there's nothing wrong with me. And so I just thought that was insane. And so I remember Dr. Yan telling me about a very famous and probably the leading expert in Germany. And so I looked up his email. I emailed him and said, there's a patient in Italy. I don't know if you know anybody in Italy. I don't even know if this email is going to go to you, but she's locked in the mental health ward because they don't believe her and they'd never have heard of parosmia. And so he emailed me back. He copied the lead physician on this area in Italy, and I provided the hospital name, her information, and I gave the girl all of this physician's information. And so they got in contact and they believed her. And now they are obviously, treating her for parosmia, but people don't know what this is. And so that's why I think the support group has been huge. And so what to do, but pretty crazy story. And I can't make that stuff up. So.
That is for sure. That is for sure. And interestingly, I have lost taste and smell, not because of COVID, but a different virus. And our president of this chapter has also lost taste and smell. Mine, I think, is back. Do I know it's back 100%? I have no idea. I just know it's better than it was. And I can't compare to, here's what it was before I had the loss, and here's what it is now. It's just something, you keep hoping will improve. And we certainly hope that for you, Julie, that is for sure. Let's see, I think we have one last question. Are there any unique features of the COVID virus itself that makes these conditions more common? So back to you, Dr. Yan.
Yeah, that's a great question. I mean, I think, this virus, SARS-CoV-2, it's constantly surprising us and how many different organ systems it can attack, and people are getting things from anything from myocarditis and decreased pulmonary function for months on, and to neural and sensory neural effects as well. I think we know that in terms of the peripheral olfactory epithelium, those high receptor levels of ACE2 really put them at risk. And I think the actual sheer size of this virus is a lot smaller than some of the other viruses. And so they think that it's able to bypass some of the respiratory epithelium, at the front of the nose. That's why maybe people aren't actually describing as much nasal congestion as your common cold. And so it probably bypasses it to physically attack those other areas of high ACE2 receptors, which are the smell fibers for the small epithelium.
Very interesting. Well, I think that our time is up. I want to thank everybody for coming. I want to thank you, Dr. Yan. We all join in thanking you for this presentation. I think we all know somebody who's been affected by loss, maybe not distortion, but I think that's a new wrinkle that we need to be aware of, and appreciate all the efforts you are making to help these thousands upon thousands of sufferers. I appreciate it very much. On behalf of ARCS, Julie, thank you so much. Dr. Yan, appreciate it. And all of you have a wonderful rest of your day.